An inexpensive way of treating severely involved mandibular anteriors is with the Priester splint. Let's talk about how we evolved to that point. Early attempts at splitting including the non-parallel horizontal pin splint, the Maryland bridge, and the Rochette splint. And these are the references for those particular procedures. The non-parallel horizontal pin splint was developed many years ago, and we can see the pre-op on the left, and then non-parallel holes are placed in the tooth, hopefully above the pulp, and then we take a rubber base impression at that time, which we made a casting, and each of these individual pins is specific for the splint. On the right, we can see where it's splinted. It's being cemented in, and we can see the final result. And yet we can see on this, there are certain complications with this. This is a 40-year post-op, and the problems that we have with this, number one, I think it's very apparent that this is difficult to do. Secondly, you got the danger of devitalizing the tooth, and it's impossible to repair if something goes wrong there, and obviously there's no way that you could do endo in these teeth should they become non-vital. And finally, it's unesthetic with that silver showing in the lower anterior. But anyway, the case that we just saw was a compliment of Dr. Jack Turbyfill, who practices in West Columbia, South Carolina. Here's an interesting commentary on the Maryland bridge. Dr. Stuart Hallbauer allegedly placed a resin-bonded bridge in the mouth of a Procter & Gamble executive several years before the patient moved to Maryland. Once he moved to Maryland, Dr. Levitas and Dr. Thompson were amazed at this restoration and the fact that it had been in for some time. And in the early 1960s, they took it to the University of Maryland, where it was dubbed the Maryland Bridge. So here is one modification of it. Here's another modification of it. And it was solid plate on the lingual. Early bridges were cemented. Later ones were resin bonded. And unfortunately, the ones that were cemented tend to come uncemented, so it somewhat lost its appeal. Here is a Maryland bridge recently done in 2013 using the Zirconia modification. And you cannot even see where the bridge is until we outline it here. So this is the post-op view showing it on number 7, a very aesthetic result. And why did we not suggest to this patient that they have a single tooth implant there? Although the tissues look quite healthy, let's look at what the patient looked like preoperatively. Here we see the post-op view of number 7 and the aesthetic result that we were able to obtain. I'd like to focus your attention on the quality, health, plaque control on this particular patient. This appears ideally healthy, and there is no plaque, and the patient has been using the simplest, least expensive mouthwash, which is another video. But why did we not do an implant in this area? Well, although we have what looks like ideal health, if we look at the x-rays on that in 2013, look at the bone loss on number 7. Look at the bone loss on the centrals, and we can see on the lower left the bone graft fill, or the bone fill that we've attained, and the crestal density showing that we do have a healed periodontal lesion. But certainly those teeth do not have a great long-term prognosis. To the right, we see the mandibular teeth and the severe bone loss there. Obviously, most of you feel that those teeth are hopeless. But we did a Priester splint on the lower right, which we will discuss on the next video. So, here we see on tooth number 15 why we did the Maryland Bridge, on this case, rather than a single tooth implant. You can see the numbers here on age, smoking, diabetes, molar type, probing deaftification involvement, all three on number 15. It scores a 16. And if you'll remember on the original PowerPoint animated that we did on the Miller-McIntyre periodontal prognostic index, anything over a 12 was a less than a 50-50 chance. So we treated the patient, age remained the same, the patient stopped smoking, did a better job of controlling the diabetes, but still was not ideal. The molar type remained the same, the probing depths were reduced, and certainly with probing depths in the 8 and 9 millimeter range, we were not able to get total pocket elimination. There were 3 furcations involved. On number 15, mobility was 2. And on the right, we can see we brought the score down to a 10, and according to the Miller-McIntyre prognosis index, patient periodontally has a 67% chance of keeping the teeth for 15 years, and you will remember how nice the tissues look. The case is quite stabilized, and in all probability will not have any problem meeting the 15-year prognosis. But we're not dealing with tooth number 15. We're dealing with tooth number 7. Age remains the same. Smoking, diabetes, molar type does not count. Probing depth, we've got down to a 1. No furcation involvements on the anterior teeth. So this scores a 5. And you'll remember that what we're doing is trying to hold the area to a 5. But given the overall bone loss in the case, it seemed impractical to just do a bone graft in that area and to do a single tooth implant. Doing a Maryland bridge using zirconia was perhaps the treatment of choice. But here's the way the patient looks, aesthetically sound. But one of the problems is with that zirconia bridge, what if one of those teeth becomes non-vital? And trying to cut through that hard zirconia to do endodontics could be problematic. I mentioned that the patient was treated non-surgically with root planing and a non-surgical bone graft. There will be a video on this that will be added to our series of lectures at a later date.